Hi, and welcome to the Digital Health Canada Showcase. My name is Mark Castleman. I'm CEO with Digital Health Canada. I'm really pleased to have a session sponsored by Hillrom today talking about the value of a unified communications platform. Today, we have the pleasure of joining us Angela Kaufman, Senior Manager, Product and Strategic Alliances with Hillrom. Angela has over a decade of healthcare experience in marketing, product management, and strategic partnerships, all focused on smartphone communications at the point of care. Volt Mobile was the first healthcare smartphone application for voice, text, and alert and alarm management. Angela has been integral to its vast adoption in the US and to its expansion into a unified communication platform at Hillrom. And as we get into the objectives for today's session, and I bring Angela into the conversation to share more with our members at Digital Health Canada. We're really excited about these showcase opportunities because they do help us to deliver on our mission at Digital Health Canada of connecting, inspiring, and empowering members across the country. Today, the objectives of this particular session will be to review the key health system challenges to be addressed with a unified patient-centric communications platform, and talk more about the key components of that unified platform to expand interoperability, integrate alarms and alerts, and bring the patient into the communications loop. As all of you know, communications are critical in healthcare today, not only from a process efficiency standpoint. For you who are caregivers, nurses, clinicians, you spend probably a quarter of your typical workday communicating. We have huge challenges in terms of burnout and nursing retention, and need to make sure that communications are easy, efficient, and effective. And of course, at Digital Health Canada, we do frequently talk about patient safety, and our partners at Hillrom are committed to patient safety, reducing adverse events due to communication failures, and ensuring that responses to those critical events are immediate and based on accurate and evidence-based information. So without further ado, let me pass it over to you, Angela, and welcome to the showcase here today.
Thank you, Mark, and thank you all for the time. I'm excited to be here today and discuss some of those key health system challenges. And we're going to look at how we address those challenges with a unified patient-centric platform. So Mark highlighted some of those, and we'll dive into expanding interoperability with supporting cohesive, collaborative communication, integrating alarms and alerts, and then ultimately bringing this all back to the patient, because that's what it's all about, ensuring that the patient is within the loop of communication and is able to be treated and cared for appropriately. So let's dive into the first category, which is expanding communication interoperability. So we hear about this all the time, and it's no surprise that our care teams are burnt out. More than ever, hospitals are experiencing staff shortages and increased pressure from demands not only with patient care, but also with the various systems that are being implemented and inundating caregivers with too much disconnected and unactionable data. With all of this data coming at the care teams, it becomes challenging to know what they need to deal with right then and what can be handled at the patient's bedside. And some statistics that we found was that a single unit can experience more than 150,000 alarms per month. And can you believe that of the 150,000 alarms per month, on average, 95 of them are actually false alarms. So just by thinking about the number of data and information that is coming towards the caregiver, if we can reduce that, if we can streamline that data, we can have the caregiver spending less time on a machine, less time on a device, and more time at the bedside with their patients. So to do that, we want to bring together the data and deliver those actionable insights. It all starts with understanding where the data is coming from. And this is what we call data capture. So this is the medical devices, whether it be the physiological monitors, the infusion pumps, the bed itself, the EMR, information that is pulling and populating data through a medical device integrator or through other forms of traffic, and ensuring that we understand that data by normalizing and analyzing it. So once we've captured that data, what do we do with it next? A unified communication platform should be able to populate the data and then decide and create events, whether that be an alarm notification. So the information coming off of the physiological monitor, should that information be filtered and alarming the nearest caregiver? Or maybe that information should be stored and retained within the EHR. So allowing for an EHR integration so that we're sharing information across the systems and we're not leaving it in one place and then in another, building up that data overflow that we talked about earlier. And as you start to understand the data more, is there an area of opportunity for research and collaboration amongst yourself and with other organizations? So we can start to normalize and build trends of what patient population information is happening. And then when we look at the data, we're responding to it in real time. But as you accumulate it, is there a way to move from reactive to proactive, where you're starting to build out enough of your information to then capture alarm trends and predict what's going to happen, whether it be through surveillance, algorithms, or other smart mechanisms to understanding where the patient will alarm next and what those trends are to those patients. So that's the first component of expanding communication interoperability, understanding what's happening with all of that data. The second aspect, once you understand the data, is where is the data going to? And this is an actual picture of a customer prior for them implementing the Volt platform, where I saw a caregiver having multiple pagers on their, what we call the tool belt, but on their waistband, to the point where the pagers and the phones were actually weighing down their scrubs. And it's laughable, but we all experience this today, where there are just too many communication devices. And for each device that the caregiver has on their person is a siloed workflow and a siloed team that is allowing them to respond to that device. And so what ends up happening is you're not creating a cohesive strategy of how people communicate with whom. And in fact, oftentimes numbers, the physical phone number to which to reach that device, isn't tied to the person carrying it, but rather tied to the legacy phone. And so what we've seen is on a smart board on a wall on the side by the nurse's station, they'll actually write the extension numbers of each phone. And as your shift starts, you'll pick that phone up and then you'll write on a sticky note the number of the charge nurse, the number of the nurse covering patient 2 or patient 3 in room. And what's happening is you're pulling out a piece of paper to place a call on a legacy phone. And that's not efficient at all. At the shift change, that phone number changes entirely because it's tied to the device itself. And so what we need to do is establish a mechanism where you standardize all of that information on one device, where the phone numbers and the calling is no longer tied to the device itself, but tied to the user profile. And that user profile is not dependent on their name of them, but also the role that they carry and the information that they are responsible for. So in addition to standardizing on one phone with phone calls, we also want to integrate alarms and alerts and allow for a place for secure text messages. So once you have that communication platform on the phone itself, on the smartphone, that's just the hub. That's the beginning of workflow, but also recognizing that there are other third-party applications, other really meaningful tools that you can use, whether it be EMR barcode med administration with Epic Rover, or medical applications for lookups and references. Once you have that standard platform, you can then start building your communication tools and framework so that the caregiver is able to drive functionality and workflow to the device instead of carrying multiple pagers or multiple phones and having siloed conversations. The next thing we want to look at is how do we connect the care teams? And the problem that we see today is that these complex care teams are disconnected. Oftentimes across the organization, what you'll see is that there are different teams that work in silos and that they manage patients in different ways, but they don't share the same communication platform. I mentioned the whiteboard example earlier. These are some pictures of that happening here, where you're writing names and phone numbers on a whiteboard. But if you're not in that unit, you don't get access to that whiteboard. So how do you know who to call? What if that person changes shifts for that day? How do those updates get transferred, not just across the unit, but across the entire health system? And then when we think about an enterprise communication, it's more than just the unit-based or the team-based communication. It's also understanding who's coming in and out of your hospital. Who are the providers that might be working in a hospital one day, but then moving to another affiliated hospital the next? Or maybe they're going into the clinic. Are they able to be reached, and are you able to talk to them in a similar way? And so we really want to tie all of that together. And the way that we've done it is through a unified directory, where you're able to have the flexibility to understand every single person within the organization and where they live in the directory. So it's more important to know who to call versus how to call them. And what I mean by that is oftentimes you don't need to know the name of a person, but rather the function that they serve and where they serve them. And so when we think about this dynamic directory, we want the clinician, the provider, the nurse, the ancillary support staff, we want them to be able to go into the directory and easily flip the switch to see who they're looking up, whether it be by names, by roles, by room numbers, or even by patient assignment populating directly from the EMR through an ADT feed. So now I can look up and see who is the care team surrounding my patient, send a group message, and start that conversation. We also want to be able to integrate to third-party systems. So I mentioned the ADT feed through the EMR, but it's vitally important to also pull in other information like on-call schedules and different assignments coming from medical devices. And then once you understand kind of who is in your directory, what your team collaboration looks like, we notice that there's also a challenge that's being faced around transitions, where a shared communication platform isn't enough. And we want to be able to replicate those in-person workflows, because ultimately what's happening at shift change or transitions, if a patient is being administered or transferred into a different unit, we need to have the care team and the conversation to flow with those changes. And the problem is, if it doesn't flow with those changes, you create another siloed event and you're unable to replicate perhaps those in-person workflows that might not scale when you think about the entire health system. And so we looked at a way to introduce those seamless shift transitions and also just start thinking about discharge planning or transfer planning. So by providing a mechanism for smarter conversations, we're able to give interdisciplinary teams the context that they need to communicate with other team members or people that are working around the patient. So we do this in a couple of ways, just to give you an idea of what this could look like within your facility, where we set up unit, team, and patient-centric chat rooms. And we're able to show what's happening pre and post any shift change. So if I come onto the unit and I take over for patient Laura Roberts, I can scroll up and see the conversation that the care team had around the patient. And I can also introduce non-members into that conversation if we're planning for discharge per se. I could introduce the case manager or the social worker as we prepare for discharge and work that patient through the system. And what we've seen with some of these steps in terms of simplifying clinical communication is we're able to improve efficiency in that patient flow. In terms of total optimization, once you implement a unified communication platform, we've seen approximately 80% reduction of time spent on calls. Because now that you know who to reach out to, it becomes simple and faster to get a hold of someone via text message or an asynchronous update. We also recognize that the constant kind of hunting and pecking, trying to find people, using the whiteboard example again, or looking people up in the call directory, we're able to save approximately 7 minutes for a nurse reaching out to a physician and upwards of an hour for ED throughput and wait times. And then when it comes to discharge, one of our organizations noted that they saved 34 minutes in time to discharge because they were able to push people through the system based off of some of the automated mechanisms that we're going to talk about next. So in this next section, as we understand the challenges again, kind of reverting back to those challenges, there needs to be an understanding of how we handle that data that I mentioned earlier and incorporating those workflows into incoming alerts and alarms. Because it's not enough just to understand the data, we have to handle the data appropriately and ensuring that we don't have alarm fatigue. So reverting back to those healthcare challenges that we're all facing today, one of the biggest ones that we see is alarm fatigue. I mentioned this a little bit earlier, but patient monitoring devices can transmit tens of thousands of signals every day. And this information, if not handled correctly, can flood the caregivers to create alarm fatigue, where essentially they become desensitized to any alarms that they hear because they hear it so commonly. And instead of it being an actual event, they say, oh, that's just a nuisance alarm. That's not real. My patient is fine. And so what ends up happening is you're increasing the response times because the caregivers are not checking those alarms because they're used to and recognizing that that's probably a false alarm. And with that, we risk the potential of clinical errors, either by missed, erroneous, or delayed communication. And you can't blame the caregivers for doing these things and ignoring those alarms or being desensitized by it, because that's the system that they have in place today. And it's too hard for them to work through those multiple alarms that are coming to either their phone or the overhead page because they've never had a way to streamline and to look at, how do we improve the traffic of information and notifications that are coming to them. So before you can implement a alarm integration, you have to understand and analyze the alarms that you have at your organization. And so going back to that unified communications platform, you need more than just an alarm management tool. You need a way to analyze your existing data so you can understand and manage those alarm trends. Therefore, then you can look at the design of the data that's coming and in real time understand what will happen next. That'll help you guide through those different workflow decisions for each alarm, because every alarm has a different workflow and every patient population has a different workflow. So working with your alarm committee, our services team designs out different workflow groups to ensure that we can reduce that alarm fatigue. And then lastly, we want to filter any of those non-actionable alerts. So that way we don't create the desensitization problem that we talked about earlier, and that caregivers know the information that's coming to them is actionable and something that they can address right away. So here's an example of a relatively complex process, current state for alerts and alarms. And this is a pretty common process that we see when we go to do our pre and post assessment for alarm workflows. So I'll walk you all through this workflow where essentially a patient is showing a deterioration. The monitor tech notices the change in the patient's state, and the monitor tech sends a page to the assigned caregiver. They actually have to look the caregiver up. It might be a sticky note placed on top of their monitor. It might be written down for the day, but they have to look that that caregiver up and look up the page number and send the page. But the monitor tech doesn't receive a confirmation when they send the page. It's just one way. So there's no way for him to know if the caregiver received that page. So did they receive it? Was it missed? Should I send it again? These are all questions that the monitor tech has to handle in real time. And so to be safe, the monitor tech sends the page again. And the caregiver receives the page. In that instance, the caregiver then decides, okay, I need to call the monitor tech back. I need to understand what's happening more to the patient. And they have the view, they have their eyes on the patient. So let me see what's happening. They pick up a phone, they call the monitor tech. The phone rings. Is the monitor tech busy with something else? They call them again. They get on the phone. The monitor tech explains, go and see your patient. They go and address the patient. It's a very complex workflow. Maybe that's not exactly how it would play out, but just an example of steps that have obvious gaps and breakdowns of where communication and efficient communication can solve this. So now let's look at that same workflow, that's been automated and built out with actionable insights. So in this scenario, the monitor tech is not involved at all. In fact, the monitors are integrated to the alarming system where the caregiver is able to receive in real time an alert showing that there is a deterioration of the patient. And they're able to swipe open and view the waveform in near real time that's connected to the physiological monitor. They're also able to see trends and strips of what's happening with the patient so they can get a quick glance on the phone and understanding what's going on. Then they can go into the room, address the patient. Similarly, the monitor tech has access to the caregivers assigned to the patient, and on their computer or on their phone, they can send a text message to the caregiver covering that patient, having them go and address and check them out. In that scenario, the caregiver can open the waveform in real time on the phone and be proactive, or they can go into the room directly. So when our customers have deployed and looked at their existing workflows and leveraged systems to allow to enhance those workflows and insights, we've seen quite a bit of changes. Most often, it's that reduction in nuisance alarms that we talked about earlier. And in some cases, 50% reduction of alarm notifications are filtered and configured simply based off of the workflow design that your organization does. And that way we can establish what the right alarms to be sent to who, and then what those backups and escalation pathways look like. So our team would work alongside with yours, our clinical services folks, hand in hand, so we can build out the directory, we can understand those workflows, and we can really define the proof points of when alarms should and shouldn't be sent, and then what those escalation pathways are. We've also noticed some reduction in automation with process waste, as well as communication failures. And ultimately, when we're thinking about workflows and we're thinking about how we automate either alarms and alerts or automate systems, the goal is to have more time spent at the patient. And so what we found was with improvements within workflow design and clinical directory design, that it allowed for an increased amount of caregivers spending time at the patients. In some instances, 30% increase of direct time with patient care. And that's really what it's all about. We want to not provide another, a unified communication tool shouldn't be another tool or another system to overwhelm your staff, but rather it should be a tool that creates efficiency so that they're spending less time on a device or less time on a computer and more time caring for the patient. So lastly, that brings us to how we engage patients with their care. You know, we talked about the unified communication platform and how a lot of the needs are addressing staff burnout, addressing workflow design, and ensuring that we're understanding the data and we're understanding what's happening to the patient. But at the end of the day, we also need to engage the patient in their care and ensuring that they have a proper patient experience. And so right now, what we're finding in terms of healthcare challenges is that there are long wait times, that oftentimes the patients are left alone or they're not given the appropriate guardrails. And so there can be a negative patient experience. And unfortunately, in some cases, there's harm done because of falls risks or safety issues. And so what we find is around 50% of patients expect a better care coordination and responsiveness, but they're just not getting it. And what that means for you all as within organizations is that patients will then shop around. They'll go to different hospitals that have the better care or the better scores and ratings. And so really there's an increased expectation for patients to have the best quality of care. And they're looking to hospital leaders and staff to provide that. So we think of patient experience more than just a nurse call button, more than just a pillow speaker, but allowing for patients to be empowered to participate in their care. Whether that means that you allow for a platform for the patient to know their caregiver, their care team, and their surroundings, that they're able to communicate detailed requests and not just send a request for ice chips or for food or for help, but to be able to track those requests and see the status. Did someone respond to me? Am I just waiting? You want to be able to show the patient that you have active requests in progress and that someone's addressing it. And it could be that they're addressing it and they're showing it in real time on an interactive iPad for the patient to control and update. It also could be where the caregiver calls back in and talks to the patient on the phone and says, we'll be there in 10 seconds. Allowing for that patient to understand what's happening with that stay and then gain knowledge on the condition, procedures, and medication. So we have a patient engagement application that runs on an iPad that's given to the patient in the bedside. And within that application, they're able to interact with their caregivers by making those requests, either manually with their fingers or speaking audibly and making that request. They're also able to understand what's happening with their stay, and they're able to tap into education portals, learn up and understand what's happening with their treatment plan, and get a better framework of what's going on within the organization, whether that be integrating the system to your food ordering service or integrating it to your EMR. Also looking at ways to make their patient stay more enjoyable, like incorporating entertainment, education, and other tools within that application. The goal of this is to move patients out of the facility faster. We want them to enjoy their time. We also want to reduce any adverse events and safety issues, whether that be getting out of the bed and reducing falls risks or other forms of issues that might come up and increase and extend their length of stay. Here's an example of the care team information on Volt Experience, which is our iPad application, where you can see the care team surrounding patient Jones. And you can also see what's happening nearby within the organization. They can look up information around the hospital. They can look up that cafeteria menu, that floor map. They can see a list of TV channels and interact with the different folks within the organization. And then additionally, here's some information around making those requests, tracking where those requests are, seeing what the completed requests have been, and allowing for that patient to have at their fingertips a coordinated experience. And then if they need to talk to the patient, having that information pop up where the caregiver, in this case, Gloria, can call into the patient and see how they're doing. And then lastly, education and understanding what their procedures are, and then what comes next for them when they get into discharge. So when we think about enhancing the patient experience, some of the outcomes that our customers have received is based on tying together those alarm workflows, tying together those nurse call integrations, and the patient experience application. We've seen upwards of 70% reduction in overhead pages that ultimately lead to a quieter environment. And as we all know, a quiet environment leads to more sleep for the patient, less anxiety, and faster discharge. Additionally, when you implement automated systems like nurse call and patient request systems, you're able to see reduction in time spent addressing those requests. So once you've built out the automation and the workflow of where the request should go and who those backups are if the request is missed, you're able to drive to faster responses to the patient. And what that ultimately leads to is increased patient satisfaction. We've noted a 14% increase in patient satisfaction scores that are tied to noise reduction, that are tied to increased response times, as well as a better understanding of their stay and their care team, how they're being handled, what the tools are in place. It goes a long way when the caregiver comes into the room and explains, this is my device that I'm using to enhance your care. And this is your device that you'll use to reach out to me. Let's test it and see how it works. See how quickly I can receive that notification. And really by engaging the patient in their stay, those patients feel empowered and ultimately leading to that better satisfaction scores. So at Hillrom, we think that these products are better together. that we can unify your communication platform and connect your care with the power of Volt platform. Now, we talked about all of these products in different aspects, whether it be nurse call, patient engagement, alert and alarm management, a mobile unified communication platform, or real-time waveforms with patient data visualization. But underneath all of that, it's important to know where your medical information is coming from via medical device integrations, allowing for reporting and analytics that covers all of the products so you can track, analyze, and rebuild anything that needs to be. And then integrating to other systems. So while we think we're better together, we certainly understand that there needs to be interoperability and integrations to other third-party systems, and in some cases, even competitive systems. And so allowing a framework for that system integration to ensure success and that we're not creating more siloed workflows. And tying all of that together, it's important to have clinical design teams, implementation and support services that can partner with you to build out these workflows and ensuring success. Thank you all so much for the time today. We're going to open it up to questions.
Well, thanks very much, Angela, for sharing with us some of the great capabilities we're looking at in terms of the improved patient satisfaction, great enhancements around patient safety, and the process efficiencies, really helping to deal with some of those challenging issues from a workforce retention issue and just the burnout that so many of our clinicians are facing with the increased intensity and duration of workload they've been under. We've got some questions that have come in. I'm really interested to learn more from you about some of the formal process workflow enhancements that you talked about, as well as the smarter conversations and chat rooms. That sounds like a really great innovation. Let's start with the patient side. We had some really good questions on your last points there around patients. The first question comes in, actually begins with a good observation. It says hospitals are at risk of creating yet another silo for virtual health services in their rapid scaling of this necessary option for care. What advice do you have for institutions that may have aging infrastructure and immediate needs for increasing digital communication and virtual care?
That's a great question, and certainly becoming more and more common as we think about the shift in the last 18 months to care at home, to virtual care, and to ensuring that everyone is staying safe in the best ways possible. I think before you implement a virtual care technology, it's important to understand the existing infrastructure that you have already and how you're going to set up the virtual care environment. So with anything, any unified communication platform, I think it's important to create a stakeholders group. So you're getting buy-in and you're getting understanding of those workflows across the organization. And you're not just creating a telehealth or a virtual care environment set up for one population or one group of users. And then if you can, ensuring that you're tying in any of the virtual care setups through your EMR or through your other systems. So that way the information is transferring and you're not, once again, kind of setting up a siloed organization. I'll pause and see if anyone from my team has anything else that they want to share with regards to that question, but I think it's just similar to the unified communication strategy. You have to understand your workflows and you have to evaluate where those potential gaps are going to be, those gaps in care, and then what your workaround is for those gaps. But we're all going through this right now. I don't know if anyone has the perfect solution for virtual care, but we're all sort of thinking about the same problem of how we tie all these solutions together.
Well, and with that, let me also welcome Todd McCallum, National Strategic Accounts Director for Canada, as well as Melanie Tinney, the Director of Marketing Care Communications at Hillrom. So we have a really strong strategic team here today, and I'll pass it over for maybe some further thoughts on the strategic issues around aging infrastructure and increasing digital communications and virtual.
So the only thing that I'll add to that is it is okay to phase your implementations. So even if you have a particular need you want to go after and that's your first priority to solve, you can absolutely solve that first, but it's helpful to make sure you have the context of that full vision so that you aren't going to end up creating another silo. Because once you do have that greater vision in place, you can absolutely phase your implementations to where you can budget and move your people, because it does require a lot of people to do these implementations as well. So there can be a very strategic rollout that you put behind it based on your prioritization and your available resources to do so. So ensuring that the platform can scale to everything that you're looking to achieve over time, and that it's going to be interoperable to work with additional solutions that you might want to bake into that as well.
I'll throw on 2 cents on that one as well. Speaking of the silos, I mean, I think everyone hates them. I hate them. And I think that's where we thrive, is the realities of healthcare. You look at OHTs, for example, you've got, different entities that are aligned to somehow deliver patient-centric care for a patient across different organizations with different systems like Epic and Meditech and everything else. And that's where we live, is how do you coordinate that care, remove those gaps in those silos as well, which is where the gaps is where the inefficiencies lie and the errors lie as well. So our strategy is to pull everything together, and not be a silo, but pull the silos together, because they're not going anywhere in the immediate future. In the meantime, we still have priorities we need to deliver in and around those.
Yeah, absolutely. And sticking with the patient engagement theme, we have another question around, and you talked about this, Angela, the opportunities for connecting these tools and sets of solutions with other existing tools like patient portals or other ways of engaging patients. Is there some additional ideas, or maybe a use case or some particular scenarios that you could share with us about how you're engaging patients and how these solutions are working in collaboration with other pieces of technology?
Yeah, absolutely. So when we think about patient engagement, the foundation of that is to really enhance the nurse call experience. And so moving from that traditional legacy nurse call, where the patient can kind of be mobilized to understand their stay. And so naturally, that's a nurse call integration with all of the nurse call vendors out there. We're not just thinking about nurse call with our nurse call, but making sure we're agnostic and we can integrate on top of Roland, ASCOM, et cetera. So that's naturally kind of the first point, is that nurse call mechanism. But we want to take it deeper than that and integrating to the EMRs, whether it be that care team integration, the patient portals, so that way they're understanding who's covering them, understanding what. So many times there are upwards of 20, 30 people coming into a patient's room. I recently had a child, and there was, at any point in time, even through COVID, 10 people in my room within an hour, right? And so having the ability to see who's coming in and out, who are these people, shift handoff, like that just increases the patient's control and experience and puts them at ease so that there's less anxiety. So absolutely want to integrate to the EMR, make sure we're capturing that care team information. And then we're also looking at and have integrated or have plans to integrate to education systems, and so that they're understanding their stay. So we do have an education portal within the application, so that way you can either upon discharge or even throughout the stay, just understanding your treatment plan, understanding the procedures that are happening to you, really dive deep into reading materials, but even interactive videos. And so we're partnering with different education providers who house the repository of that information and those videos, and ensuring that that can happen within our application. We're also integrating or looking to integrate with entertainment systems. So pulling in any sort of entertainment, TV, movies, interactive experiences within the application. So those are just a few that we've either started and have complete or are on our near-term roadmap to complete integrations for.
Thanks for that. Well, across the country and across the world, I know that many healthcare provider organizations are facing real challenges in terms of clinician shortages already. And now with the pandemic, it's really driving that home. Clinicians have been really challenged. The pandemic has tested our capabilities to the limits in terms of as groups of individuals, as well as individuals who are involved in clinical care. I know you're involved. Hillrom is an active participant in our Chief Executive Forum, and one of the strategic topics there is about workforce and workforce management. How do tools like this and some of the strategies that you're putting in place, help us to take on those challenges with regards to workforce burnout and clinician shortages?
I can try.
Go ahead, John. Yeah.
I can try and grab that one. I think the situation we're in now is what I'm hearing, 20% of nurses have either left the profession or left the bedside. It's more of a, I've seen that number in Canada and North America as well. And just in talking to different folks, in different healthcare acute systems, that seems to be getting validated. So the old approach, throw more beds and throw more nurses at it to solve the problem, and just through brute force. Not that that's always terrible. That luxury is not on the table, at least in the short term, even in the next 5+ years. And in the meantime, you also have the spike, especially in Ontario, 3.5 years of backlog procedures. Different provinces are, slightly different in that regard. So increase in demand and reduced ability to deliver. And so how do you retain your skilled nursing staff and meet this demand challenge right now? So we say ourselves hitting it from two different angles. One, we're tightly aligned to improving clinician experience, particularly around nursing, in streamlining their workflows, reducing a lot of those nuisance alarms, and letting them focus more on doing their job, which will give them more capacity to be at the bedside, to be able to streamline those workflows and accelerate throughput through the hospital as well, right? Speed up discharges and all that sort of stuff too. So we think we're kind of in the situation right now in healthcare where we have to solve it with technology, probably, not just necessarily Hillrom, but I think in general, from a digital standpoint, I think digital is really, digital was there for virtual care to solve that problem during COVID when you couldn't see people. I'm probably going to see a similar thing happen through the acute care space over the next year or two. It's my take anyways.
Well, thanks for that. Yeah, that's a really critical issue that we need to, as an industry, keep working towards to support all of our clinicians and tackle this sort of secondary pandemic, if you will, that's going to affect our workforce. Going back to the opportunities around expanding interoperability and really supporting cohesive, collaborative communications. You're talking about integrating the alarms and alerts to reduce fatigue. We have a question from one of our attendees here about integration standards. And maybe if you could mention a few of those that a technology should have, whether it's a physiological monitor, bedside pumps, etc., in order to work and communicate with the platform.
Yeah, that's a great point, Mark. Similar to the discussions around siloed communication, we don't want to have siloed protocols. And so it's really important that, when you are looking at and evaluating technology, that they're using standard protocols. So that way, a year, 3 years, 7 years, you're not limited to that vendor to updating and tweaking their specific protocols. It also allows for interoperability, right? So the less that you can rely on custom integrations, the better. And so from a Hillrom perspective, we've taken that approach to build towards industry standard protocols, whether that be IHE compliant HL7 for any of the data coming off of monitors and pumps, any of that medical device integrations that I talked about at the beginning. From an alarming perspective to the endpoint device, we leverage WCTP, which is our standard protocol for wireless communication transfers. And then ensuring anything from the EMR, right? Like we know how challenging it is to work with EMR vendors, but we love to work with them because that data is so important. And so making sure that we're collaborating with Epic, with Cerner, with Allscripts, with those standard integrations that they have, whether it be from the App Orchard or their various EMR tools that they have available for third-party vendors. So does that answer your question?
Yes, I think that is exactly what this particular attendee was looking for. Thank you. More questions coming in. So this next one is around personal devices. Physicians, clinicians typically have their own personal device. We've all seen this in the care environment, multiple phones or different devices on the clinician's belt. Do you recommend the clients implement an enterprise mobility management platform first to ensure data privacy and security for personal health information within the app? What's your approach to that?
Yeah, that's a great question. So I'll kind of break it into two parts. We absolutely do recommend an enterprise management tool. We have partners with VMware, Jamf, Mobile Iron, Cisco, so it pretty much can be supported on all, but we think that's critical, especially when you start to scale your smartphone deployments within your organization. When you think of 1,000, 2,000 iPhones roaming the halls, it's important that you're able to manage that fleet of devices and ensuring that you can have ease of accessibility, whether it's pushing down new versions of the application, updating your iOS or your OS on the device, and then just managing that tool so that your caregivers within the hospital knows that this is an enterprise tool. If you give them a smartphone, they're going to immediately know what to do with it because we all have smartphones. So ensuring that you're locking down the device, you're customizing those settings to your organization so that those preferences are built towards the goal, which is that this is an enterprise communication tool. So that kind of covers the shared device model. That's going to be your nurses or your staff that's within the four walls of the hospital that are going in and checking a phone in and out every day at shift handoff. But for our providers that are moving in and out of the hospital, we actually have a hybrid model. So our providers, we recommend that they deploy the application on their personal phone and that the application is secure, it's encrypted. You can either leverage PIN locks or face identification. And then that way the providers feel empowered to use the application. And the goal there is to drive towards pager replacement. We know it takes a while to get rid of that pager for a provider. It's kind of embedded in their culture, they're used to it. But over time, what we see is as providers get used to the application on their personal phone and see the accuracy, they see everything is coming in on time, you're kind of building up the credibility for that enterprise tool that you've given them. And then they can also see the benefits of the additional data that they get and the access to the entire care team. Ultimately, that provider is able to ditch the pager. So for the providers that are using the application on their personal phone, it's slightly different in that some organizations do require providers to have that enterprise mobility downloaded directly on their phone, and others don't. So it tends to be a case-by-case basis of whether providers themselves have MDM on their phone, or if you're just controlling the single-pointed application. Not unlike having your providers using Outlook, right? It's an enterprise application. It's similar to like Epic Haiku, right? They're used to using single applications for your enterprise and for your organization. So allowing that communication application to be similar and live on their device, and then they're enabled to use it and kind of be brought into the larger collaboration that happens within the hospital.
Thanks for that. This next question is about models in different jurisdictions. And of course, in Canada, we have, each province operating with unique features of a jurisdictional model in terms of healthcare service delivery. The question from this attendee is about Alberta and asked the question about Alberta operating in an integrated operating model across the province. How is the use of digital technology in this environment contributing to overall operational excellence, outcomes, and cost savings? And then the follow-up question is around transforming workforce culture and building continuous improvement. So any takers on the first question related to an integrated operating model?
That was a mouthful. I think so. I agree the jurisdictional. I think some of the things that were cited in the question, though, are really common across different health systems, like Avera Health and others. Angela, if you want to speak to that one, but in terms of it just comes down to it's the same outcomes that we're seeing all over the place, right? So the system, I think the system is really only, in my opinion, if I'm reading the question right, only really relevant to specific organizational structures and what they're trying to achieve within that construct. So I mentioned the Ontario Health Teams, and you have the RHAs in BC, and you've got one health system with AHS, but you still have your zones and standards of care across the zones, and now obviously the sites across those zones. But you still have the same complexities of care. You got acute care, you've got primary care physicians, you've got long-term care. All these elements exist in every healthcare system, I think anywhere, but just how they're governed and pulled together. So I think the governance and all of those elements can make it trickier where, I don't know how we talk to AHS, for example, around alert and alarm management. That tends to be very facility level, right? And to have that conversation at a provincial level. Well, we've done it in the US, though. I know with one of our large health systems right now that's rolling this out across 178 different sites. There's common elements and objectives that are being defined organizationally and then driven down, and the how everything's getting implemented, and the fine tuning of that is happening site by site. Is my understanding of that one too. So I'd say that's how the AHS model would fit. You've got an overriding sort of governance and priorities and pointing to the North Stars, but then each zone and site would really work out what they're trying to achieve at the workflow level. Because also what we do is we don't just turn it on. It's tightly integrated to the way you're working and delivering care and coordinating care, right? So you want to make sure that's baked to how things are happening within a site or within a specific catchment area. So I don't know, Angela, if you want to jump in on that at all, or.
Yeah, I think you covered it well, Todd. I mean, the only other thing I would add is this is a lot to do and a lot to bite off, especially when you're thinking about a large health system. And Todd, to your example, the health system in the States, it's 170 plus hospitals within it, and just interdisciplinary teams and markets. They're not going big bang, and they're not doing all of this at once. It's very much a methodical crawl, walk, run approach where you get on the ground level at each hospital and even each unit and understand those workflows. And, absolutely, you're going to see efficiency gains if you go all in and turn on waveforms and you tie all of the integrations together on day one. But start small, and let's start with a smartphone platform. And let's look at your nurse call alerts, and then we'll pull in your physiological alerts, and then we'll pull in lab results and start talking about throughput, right? So once you kind of get that foundation of what those, what the current workflow is, and then what needs to be replicated at each unit and each hospital, then you build out to this like larger kind of operational improvement model, and you'll see gains at each step in the crawl, walk, run approach. But just know that it is a process. It's something that you have to plan out within your organization, and always go back to kind of checking and validating, okay, are we on track? What comes next in the process? And then what do we want to tackle and achieve? Because we'd love for everyone to turn everything on day one, but I don't think they would have the same level of success if they didn't walk through the process with us and kind of understanding those challenges and areas of improvements that we want to fix.
Just to speak a little bit more about our implementation methodology there, because I do think it is something that sets us apart as the first hospital that started getting into smartphone communication at the point of care more than 10 years ago now. So ultimately, we have leveraged all of our learnings over the past 10 years, more than 300,000 deployments of smartphones of users on that platform today. that we really do need to work with your individual sites, units, et cetera, to understand their workflows, but also tie that back to what your organizational goals are. And as Angela was talking about the iterative process of adding on those other phases, we are going to be constantly checking in and evaluating, did we achieve the outcomes that we set out to at the very beginning? And that isn't going to be a process that stops, 30 days after your implementation. That's something we're going to continuously come back to make sure that you're continuing to see that adoption and continuing to see the results that you have invested in for that continuous improvement. And that is absolutely a key component to our methodology that cannot be skipped or overlooked. You constantly need to do those evaluations to ensure you're getting the return you looked for.
Well, thanks for that insight, Mel. We only have a few minutes left, but I do want to thank you all, and we'll conclude at the end with a thank you, but maybe you have some final thoughts. I mean, healthcare really is the ultimate, we often say, team sport, and any great team requires amazing communications and sharing of information. So we've heard today about the enhanced process efficiency, patient safety, and patient satisfaction as critical ingredients within that formula. Any final thoughts for us as we leave today, thinking about our own communications and how we can enhance our work to create better outcomes and better experience for patients as well as our clinical teams?
Yeah, I would say, start small. Look at an area where you can go in and improve communication. Maybe there's a disjointed workflow. Maybe there's a legacy device that's no longer available, or you're ready to ditch the pager, and kind of use that as the jumping off point to establish a smartphone strategy. And then from there, you can plan the phases, which are integrating those alarms, capturing that data, pulling the patient into the experience. But start small and look at, okay, how do we address communication today? And then how do we improve that communication? And then pull in the integrations after. That would be my recommendation. I don't know if Mel and Todd, if you guys have any others.
I'll just throw in there too. I think it's as much as we can bring some intelligence into the workflow as well, and bring in some automation, just to I guess take more of that pressure off the clinicians as well, right? And improve patient outcomes before before an event is going to happen. Obviously, there's a lot of potential in there to shove those algorithms within here as well in order to be able to operationalize those into the whole care domain as well. So that's something else I'll throw in there to get an incremental additional value.
Well, thank you. Listen, on behalf of our members and participants with us today and Digital Health Canada, we're so pleased to have Hillrom with us to share strategy and ideas on enhancing communications to improve patient outcomes, the clinician experience, and improve cost savings across the health domain. We've got some big challenges ahead for all of us in the industry, and we thank you for sharing your insights today to help us to move forward and tackle those together. Thanks, Angela. Thanks, Melanie, and thanks, Todd. And thank you to our attendees and participants. As was noted in the notes, this recording will be available for sharing and for you to share with your colleagues as well. So thanks everyone for participating today. Have a safe day.
Thank you.
Thanks very much.